thank you all for tuning in today. We're waiting a few moments just to get everyone logged in, which should be happening about now, I think. So it's my pleasure to welcome you all to this very timely and very important roundtable on COVID-19 vaccines and cancer care, the known, the unknown, and the unknowable. And as the title implies, there's a lot of things we don't have the answer to yet in this critical area, and the scenario is changing rapidly. But hopefully after today, we'll know a bit more. So my name is Ben Hirschler, and I'm a writer on health and science and a former correspondent for Reuters, and I'll be moderating the session today. We've got a very distinguished lineup of experts on oncology, immunology, virology, who are going to give their views, and they're going to answer your questions. And we're going to discuss a range of topics. So the science behind COVID-19 vaccines, the risks of their interaction with anti-cancer therapies, the ability of patients to mount an immune response, the duration of post-vaccination protection, and the best time to administer a vaccine in cancer care. These are all obviously vital questions for doctors and patients and carers. But let me start by introducing the speakers and explaining how this webinar is going to work, and especially the key point of how you can ask questions. So your experts today are the president of ESMO, Professor Solange Peters from the University Hospital of Lausanne, Professor Ravindran Kanasvaran of the National Cancer Centre in Singapore, Professor Thomas Powles from Bart's Cancer Institute in London, Professor Leif Eriksander from the Charité University Hospital Berlin, Professor Uwe Gerd Liebert from the Leipzig University Medical Center. And we're going to have a roundtable discussion for about 40 minutes, followed by the Q&A at the end. You can submit your questions during the roundtable, but they will be answered at the end. And if you want to submit a question, please fill in the Q&A box at the bottom of your screen. We will not be using the raised hand option, so don't try and ask a question that way. If there are any unanswered questions at the end, the ESMO team will try and reply via social media after the event. But first up, Professor Sander is going to give us a short lecture to explain the science of the vaccines that have been approved so far, including how they work, their safety, efficacy, and their potential. So over to you.
Thank you very much. Thank you very much for the invitation and for the challenge to give you a quick rundown about the technology and the science behind the COVID-19 vaccines in about 5 minutes. So let's see if we can do that. If everybody can see my presentation. So a little bit of an introduction to COVID-19 vaccines. So I think we always have to remind ourselves that a year ago we were talking about a mysterious pneumonia that had occurred in a province in China. 7th of January, the genome was sequenced and mapped to a beta coronavirus. And a few days later, Chinese scientists published the whole genome sequence, and that was basically the starting point for the development of SARS-CoV-2 vaccines. The reason being that it's a beta coronavirus that is closely related to other coronaviruses, such as the SARS coronavirus and the MERS coronavirus, and there had been development of clinical and preclinical candidates for vaccines against those viruses. And we knew quite a bit about potential targets, and the target that has been addressed by virtually all of the vaccine candidates that we have in development is the so-called spike protein, this prominent surface protein of the SARS-CoV-2 virus, with the receptor binding domain with which the virus attaches to the host cells. So, and it was well known that this is a good target for neutralizing antibodies. It was also known that it needed to undergo conformational changes to bind to the receptor, and which is why some of the companies have chosen to use prefusion stabilized versions of this spike protein as their vaccine target. So the types of vaccines that we'll be dealing with mostly here in Europe are the mRNA vaccines that already have been licensed in the EU and elsewhere. I'm going to talk a little bit about those. Obviously, Also very exciting, the adenoviral vector vaccines that are being developed in several places, and obviously in Oxford. And we are also going to see some recombinant spike protein vaccines. I guess elsewhere in the world, there's also been development of inactivated vaccines, mainly in China and India, and also South America. And there are also some replication competent vector vaccines underway, but those are probably, and DNA vaccines. But those three here on the right are probably the ones that we're gonna see in the near future in the EU. So mRNA vaccines, just as a quick reminder, I guess most of you are familiar with the concept. So this is the mRNA in the two licensed vaccines now is a nucleoside modified mRNA. So the building blocks of the mRNA have been slightly modified to make it a little bit less immunogenic within the host cell. It's encapsulated in a lipid shell in order to allow it to enter the host cells, and the sequence is modified in a way that you get a very efficient protein translation on the host cell ribosome, very much like a viral infection. Production of spike proteins. In this case, the spike protein in the BioNTech and the Mrna vaccines are membrane anchored, so they're not necessarily being released. And it's also not clear whether some of the vaccine is also taken up by antigen presenting cells, which can then kickstart the adaptive immune response by presenting antigen to T cells. And of course, we also get activation of B cells. And those vaccines are indeed immunogenic. We knew that from other candidates and preclinical models before. These are clinical data from the BioNTech candidate. And they had initially tested two different candidates, the B1 and the B2 version, one being just the RBD and the other one being the full spike version. And they settled on the full spike, which I believe was a good choice. And the final dose that is being administered is 30 micrograms. And we can see that this vaccine is fairly immunogenic, both in people aged 18 to 55 years and also 65 years and older, which is good to see. You can see high antibody titers and also high neutralizing antibody titers. If you compare this to reconvalescent individuals, this is a very good response, high immunogenicity. What we do see with these vaccines, both with the Moderna and with the BioNTech vaccine, is that we see a fair amount of what we reactogenicity. So especially younger vaccinees will feel a little bit fatigued, headaches, so a little bit like a mild viral infection. There is also there's also a substantial placebo effect here if you see that, and generally older individuals tend to tolerate the vaccine a little bit better, but overall all of these reactions are mild to moderate, the vast majority. And the reactogenicity increases a little bit with a second dose, also something to keep in mind when you're vaccinated and when you're talking to your patients about vaccination. The safety profile is excellent of those vaccines. There are, as you know, two large trials. So one, the BioNTech trial that had enrolled over 40,000 individuals, and the Moderna trial that had enrolled over 30,000 individuals. No safety signals here for adverse events. There has been some talk about facial nerve paralysis, but that was within the normal range and was not seen as directly caused by the vaccine. And we haven't really heard anything about that since the release of the vaccines into the market. And this is probably one of the most famous graphs, and it's probably going to go into the textbooks. So this is about 10 to 12 days to build up an adaptive immune response. And from the moment the individuals have built up an immune response, you can really see there's only very few infections, very few events accumulating in the vaccine arm versus a linear accumulation of cases in the placebo arm. So there seems to be a very high efficacy, which was calculated to be around to be 95%, and it also tends to protect against severe cases. There were 9 severe cases in the placebo arm, and just 1 case in the vaccine arm where, while I wouldn't really consider this severe because that patient was not even hospitalized, there was just a transient drop in saturation. Similar data for Moderna. You could see basically virtually the same graph. Again, all this is 11 severe cases occurred in the vaccine, in the placebo arm. And I think what is of interest, and one of the aspects I guess we're going to talk about today, is to which extent these vaccines induce sterilizing immunity and can protect from asymptomatic infection and transmission of the virus. We don't know a whole lot. We know a little bit about from the animal models, and it appears to be that you have lower titers and a shortened time period of viral shedding. And this is data from the supplement of the Moderna trial, where people were swabbed prior to the second injection, and you can see there is a significant reduction, yet not a complete abolishment of PCR positivity in the vaccine arm versus the placebo arm. So we need more data on that. And then last but not least, obviously, we have the Oxford AstraZeneca adenoviral vector vaccine. So this is a replication deficient chimp adenovirus that also encodes for the spike protein. In this case, it's not membrane anchored, but soluble as far as I understand. And this vaccine has already been licensed in the UK and many other countries in the world. The phase 3 data is a bit more complicated, I would say, than a bit less straightforward than the mRNA data. Efficacy, again, against the primary endpoint of symptomatic infection seems to be in the range of 60 to 70%. As I said, it's a complicated trial design with many different arms, and there was some hiccups with the dosing of some of a subgroup of people. So we'll have to wait for a bit more data to know the exact efficacy, but there's also what I hear seems to be a good trend for protection against severe disease, which in the end probably is what counts. And I think I went a little bit over 5 minutes. That's about what I have to say. Everything else will have to be in the discussion. Thank you very much.
Great. Well, thank you very much for that overview. That's a really good basis, I think, for the discussion that we're going to have. So I'd now like to sort of broaden out the debate. As you probably all know, ESMO has been very proactive in calling for vaccination of cancer patients as a matter of priority, along with careful collection of data and education. And it's also released 10 statements that address the main issues and concerns around COVID vaccination, all of which is on the website. So at this point, I'd like to ask Professor Peters to tell us what do we know about the incidence and severity of COVID-19 in cancer patients, and which cancer patients are at greatest risk? Over to you.
Thanks a lot for the question. I think it will be the introduction of the debate. Our patients are suffering from the distressing intersection of COVID-19 and cancer. And I'd like to stress here 3 aspects of this intersection. The first one is about the risk of catching COVID-19 infection, because as you all know, we call our patients as an obligation, as mandatory meeting and appointments many times repetitively to the hospital. So even in a lockdown situation, even if our patient would like to stay isolated because of the risk, we somehow force them, ask them to come and join the hospital for many and various appointments. That's the reason why in the early series of COVID-19 patients, an excess of cancer patients was observed, meaning that probably by this open force to the hospital, our patient had been shown to be more susceptible for COVID-19 infection. Thanks to the spreading of personal protective equipment and the measures we all have been taking in the society and in the hospitals, it looks like that in the recent series, cancer patients do not really suffer from an increased risk of catching the COVID-19, but it remains a matter of debate, at least to a lesser extent than in the beginning, where we were all a little deprived on these PPEs. So second aspect is, of course, the second aspect of this intersection is the risk of delivering suboptimal cancer care. And this is about, of course, all the restructuring of our cancer hospitals, cancer structures, because of COVID-19 needs, but also because of the delays in everything we do. And nowadays, very interestingly, we suffer from the long-lasting positive swabs for our cancer patients, which sometimes themselves delay what we'd like to do to them in terms of diagnosis, but also in terms of treatment. So the second important point is suboptimal, obviously, and wherever you are, suboptimal treatment of cancer patients. But the third one, and as you ask, is an increased risk of complications and mortality related to COVID-19. And this has been shown, unfortunately, in many series and in a very reproducible manner today. Basically, our cancer patients roughly die for 20% of them from COVID-19 infections. Most of the series have been showing a range of mortality from 15 to more than 40%, even 50% of mortality among cancer patients. Who are the patients most at risk of dying from COVID-19? Unfortunately, these patients are probably, first of all, the ones who are older, of course, and suffer from comorbidities. But if we want to focus on cancer, it's probably about patients suffering from active cancer, progressive disease, the presence of a bulk of the cancer. It's probably also about patients having a smoking history, as shown in most of the series, and having what we call a poor performance status, meaning being weak because of the cancer and the cancer conditions and treatment, right? Beyond that, we have been showing that some very small subgroups or very specific subgroups like lung cancer patients, which makes sense based on what I said, hematological malignancies are patients who suffer more from COVID-19 infection and die more. And if anything about treatment, and it's still a matter of debate, it might be that the only risk might be chemo, but still there are controversial data. Hopefully, we haven't been showing that immunotherapy or targeted therapy or even hormonal therapy would increase the risk. So the message here is try to deliver your treatment optimally, because it's not proven that the treatment itself will increase the risk. However, the cancer itself will increase the risk. So that's what we have in hands. Starting from that, these three pillars of risk, right, from the incidence to the cancer care and the mortality risk, we have been creating this call for action in ESMO. It's now 43 European organizations in science, in research, patient advocacy, who call for action looking at our cancer patients. It's 26 European countries too. So the call is about vaccination. We ask to prioritize cancer patients to be vaccinated because of what I told you before. And if any supplementary priority should be given because of a limitation of the vaccine doses available, you should focus first on the very sick patients with active disease and maybe with current treatments, but call for priority for cancer patients. Then a call for a diligent collection of data, because from the trials which were nicely shown by our colleagues, what we don't know is about the real activity, depth of activity and durability of activity of vaccine, and we need to show it and measure it in research projects, in trials. And last but not least, a call for education to instill confidence in our cancer patient population, to convince them that the risk benefit is really in the direction of the benefit for them to get vaccinated, and that mRNA vaccines are safe even for them. So that's a topic we'll cover later on, but I think this call, still open to additional signature, is a very important one.
Great. Well, thank you very much for that. That's really helpful. So another thing that I wanted to talk about, one issue that's increasingly in the news at the moment, is the question of virus variants, with the new variants that we've seen emerging in recent weeks. So maybe Professor Liebert can tackle this one and address two big concerns I think are out there. First, is there any evidence that the new virus variants may be more aggressive for vulnerable populations, such as people with cancer? And second, what are the chances that the currently approved vaccines will be less efficient at protecting against these variants? Thank you. Over to you.
These questions, of course, are very important and are really pressing to the public. There are hundreds of different mutations around since the beginning of the pandemic, but very few have really captured high interest. This is mutations, for example, from Kent or from Brazil or from South Africa, and in recent days from, for example, from Bavaria, where we have all mutations that occur either separately or in combination. And the big concern is that these mutations, and at least some, like the Kent mutation from southern England, is really more infectious. So it's spreading more easily. That we know, but so far we haven't seen a definite proof for any mutation that is causing more severe disease, and that's probably an important message. So it may spread more easily, but is not leading to more severe disease. And this actually then points to this, the fact that since we have vaccines around, and we have quite a number of vaccines approved in various countries, and so it will be important to use this vaccine in priority for two different groups of patients. That is at least the situation in the European community. So it will be important to vaccinate the healthcare workers so that they are not spreading the virus anymore. And the second, and they are protected, hopefully. And the second group, of course, are the elderly. That is politically decided, and this is consensus. But then in the next row of priority, it would be cancer patients. And cancer patients, as we have heard already, are probably more prone to a severe course of the infection than are the natural population. They probably have the same risk of getting infected, but then get more likely a severe infection. So it's important to vaccinate cancer patients. And this means all different types of cancer patients. Of course, there must be precaution on the use of the vaccine type. That is quite sure. So the vaccine type, and somebody will talk about it, it should be a non-replicating vaccine. It should be the RNA vaccines that are inactivated vaccine. So things that cannot cause an infection by its own. That is very important. But coming back to the variants and the mutations of the virus, there so far is no indication that any of the vaccines available so far do not cover the mutations. This is, of course, very hard to foresee for the future, but because we do not know how the virus mutates in the future. But so far, the vaccine, the different vaccines cover very likely all different mutations that are around yet. In the future, that may change, but it's very unlikely that it changes so far. I think that's so far what I have to say.
Great, thank you very much for that. So one of the big concerns, of course, when considering vaccination for cancer patients is how well they are going to respond to that vaccine compared to the broader population. So a question for Professor Kanasvaran: how well are patients able to mount an immune response following vaccination, on the basis of our current knowledge? And what factors are likely to influence that immune response amongst people with cancer, for example, age, fitness, tumor type, and other factors? Thank you.
Thank you, Ben. That's an excellent question. And I think that would belong in the realm of the unknown. Solange has very nicely set the stage earlier, and she described how this confluence of COVID-19 and cancer, it's really something that's horrible that's happening to cancer patients around the world. So now with the vaccine, and very nicely Dr. Sander had described with his big starting slide, the light at the end of the tunnel. Will this, help cancer patients get out of this difficult situation that they're in, with higher rates of mortality, if not higher rates of infection, because that's probably not true. Now, with regards to how an individual mounts a response, there are many, many factors. There are vaccine-related factors, the nature of the vaccine, the dose, for example, whether it's optimized or not. There are patient factors that you rightly mentioned, like age and all that. Now, if we go back to the Pfizer-BioNTech trial that was published, and Dr. Sander actually showed the phase 1 data, even in older adults, there was a very good response in terms of neutralizing antibodies. However, these trials excluded pregnant women, they excluded the young for the Pfizer vaccine, those 16 and younger, for the Moderna one, 18 and younger, and they excluded patients who were immunocompromised. All our cancer patients who are on active treatment fall into that category. So they were not recruited into these trials. So that's why this is the unknown. And that's where one of the things that Solange mentioned, which was a call to action, included collecting data diligently, getting databases active, actively getting data to see how these patients truly respond. Now, what we can do, at least what I can tell you right now, is how do cancer patients mount a response? We can extrapolate data from other vaccine studies, specifically inactivated vaccines. And from that data, it is pretty clear if your immune system is intact, you're not on active treatment, you're a cancer survivor, you're cured, then you should be able to mount a good response. However, those who are on active treatment that are immunosuppressive, like chemotherapy, or those who are on immunotherapy, which is a big question mark, and I think Tom will address that in a short while. We don't really know specifically to this vaccine how they respond, but usually there's guidance as to when you should get these vaccinations if you're on immunosuppressive therapies. And usually that includes not getting it while you're on active treatment. But that's different now. The situation is completely different. You have this actively virulent virus that's going around causing mortality. So you have to, it's a tight balance between taking on a vaccine that may not be effective, but you're in a situation where you don't have a choice, because if you don't, then you're going to suffer from mortality. From an older adult perspective, or it's a cancer patient who's older, if you go by the Pfizer-BioNTech study, again, the clinical part of it showed that those who are 75 and older, none of them actually had COVID when they were vaccinated. But does that apply to our older patients with cancer? That's something we don't know. We'll probably know with more data that's going to come out. They do undergo a process of immunosenescence, but they can mount a response depending on whether they're on active treatment, whether they're not. So there's so many unknowns here, which I hope that as a community, we'll be starting to gather some data to understand a lot of these things better.
Great, thank you very much. So to sort of follow up and explore that a bit more, I'd like to find out, a bit more about, how we might expect these particular vaccines will actually work in cancer patients, particularly, again, based on past experience. And obviously, it's interesting that mRNA vaccines are not completely new in oncology, and we've seen some promising experimental work using the technology to fight tumors in obviously a different way of using this technology, and at the same time with extensive experience with giving cancer patients seasonal flu vaccines and so on. So a question for Professor Powles, and maybe Professor Sander wants to add something as well afterwards. What do we know about how patients with cancer react to different vaccine technologies? And does our current knowledge justify a clear preference for using one vaccine technology over another? Given we've got 3 vaccines at the moment, we'll probably have more in the future. Over to you.
So, thank you for asking. So I think the answer is that there are a lot of unknowns in this environment, but clearly we need to avoid live vaccines, and none of the vaccines that we're talking about today are live vaccines, none of the approved vaccines. So the first thing, really important message to say is the vaccines in cancer patients are safe, and there is a discussion about whether or how effective they would be. But as Solange said earlier, we're talking about a super high risk population who are having to come and break lockdown in the middle of a pandemic. So a really important message is that firstly, do no harm. We're not going to do any harm. We could do a lot of benefit by vaccinating these patients, and they are a very vulnerable group. One of the challenges we face as well is that in areas of limited resource, it's not clear how these patients will be ventilated, etc. So preventing this disease in this group is a high priority, and will do no harm, will generate some immunity. Certainly the RNA vaccines and the adenoviral vector vaccines, both of those appear to be attractive. And while they haven't been specifically tested in cancer patients, the hypothesis that they will work is there, and we need to test that. This is not a perfect environment, but there are very few aspects of this pandemic that have been perfect, and therefore I feel strongly that we need to press on. There are issues around the timing of the vaccine, and again, we don't have the luxury of starting the vaccine before therapy in all of the patients because we hadn't planned to be here. And so therefore the current position is let's vaccinate the patients that are in front of us and hope that we can generate some immunity as quickly as possible with these safe vaccines that will do no harm. We're not currently in a position where we can pick and choose too much, to be honest. I'm not sure any of us have all 3 vaccines and we're able to say this one for this patient and that one for the other. So again, my message is use what's in front of you, treat the patients that you can, and vaccinate them and hopefully generate some immunity. I certainly wouldn't, I'm not personally an advocate of giving 1 versus 2. I think we should be sticking to the guidelines and giving both doses. And I'm also not an advocate of mixing and maxing with different vaccines in this population. I think what we have to do is go with what we know. And there are some uncertainty around that, around this particular population.
Great. So, Professor Sander, did you want to add anything to that, or?
There's not that much to add. I fully agree about the unknowns. I feel that both the mRNA and the adenoviral vector vaccines induce both humoral and cellular immunity, which might be a good thing, thinking about this population of patients that is often older or has comorbidities. The data, the immunogenicity data, and also the efficacy data that we've seen on the older trial participants is promising, that it might also work in a slightly immunocompromised population. We don't know the correlate of protection yet, so it's hard for us to predict what type of immunosuppressive therapy would actually impact the vaccine efficacy and the success. I would completely agree with Dr. Powles that we should use what we have. I think it's the best we have, and there are also some indications that even a suboptimal level of immunity would at least protect from severe disease, which is what we want to do. So I can fully subscribe to what has been said. Great.
So I wanted to go back to Professor Peters. I mean, we touched on this briefly, but a key question is, based on our current knowledge, what's the risk of interaction with a COVID-19 vaccine and specific different types of anti-cancer therapies?
Well, it has been suggested by my colleagues, right? In our cancer patients, and probably, most probably, regardless of what they are receiving or not, there is a risk-benefit ratio which is trending into the benefit strongly for any vaccine. Of course, it's a question we have since a while, right? We shouldn't play naive. We do vaccine campaign every year for influenza, and we have been trying to answer these questions before. And still, there are some missing data. But what I'd like to say here is to stress some political messages. I remember when the vaccines were not published, we were all telling that 50% protection would already be kind of a satisfactory kind of results. Now we know that we have 90%, even more. But if it would be only 50% in some of our cancer patients, it would still be extremely important to save many, many lives in this patient population. So there are some unknown about efficacy. And basically, we believe that the safety profile will be the same for our patients as compared to the one described in the current literature. So the pro and contra are really in the favor of the pro. Maybe one question mark is about this systemic inflammatory kind of symptoms of fatigue, some itches or some fever. Would it be somehow potentially increased when you receive CTLA-4? We don't know. But anyway, again, the balance is in favor of the pro. What is extremely important here is to try to define the timing. And here in Lausanne, for example, we have been setting down a measurement of the antibody titers over time from the second injection up to a year to try to document, following the call of ESMO, what's happening in the patient. And I was surprised yesterday to hear in one of these meetings that there was a trend of decided not to vaccinate patients on the rituximab. What do we know about it? Should we make this kind of decisions without knowing? Maybe if the resources are limited, maybe if you really have to prioritize to a very, very narrow extent the vaccination process. But if not, I'd like to remember that this has been done, right? We have been trying to give tetanus toxoid vaccines, pneumococcal vaccines, influenza vaccine in patients receiving rituximab. The result was lower, but still there was a response. Some marginal zone B cells still are CD20 negatives. So we have to be careful, and like Dr. Sander was telling, there is also a component of T cell response. So all of these unknowns shouldn't make us make science or guess science beyond the data. And we have to be very careful when we are physicians and not infectiologists, and basically even not researchers, not to make statements which might endanger patients. So to me, all patients under chemo, under IO, under hormonal therapy, under targeted therapy should be vaccinated. Some of my colleagues would say if you can avoid to give the vaccines the day of a high dose of steroids, it might be preferable, but even if you have to do that, do that. And that's my main message. I mean, at the time being, we shouldn't compromise this protection.
Yeah, great, thank you. So maybe I can just go back to Thomas on this point, as you talked about timing as well, and you made the point that at the moment, obviously you have to do what's in front of you, but maybe, looking a little bit down the line, you will have more chance to optimize timing. I wondered if you had any thoughts on what is the ideal timing for a vaccine.
I was hoping you might ask me that. So I don't know the answer to that question. I mean, common sense dictates that starting as far before or away from immunosuppressive treatment as possible makes a great deal of sense. And I think there would be universal agreement that vaccinating patients in the workup to their, so suspected cancer patients on a pathway who inevitably are going towards chemotherapy, I think we would agree that vaccinating as quickly as possible would make sense, because delaying that vaccination until they've started treatment, well, number one, you've put them at risk because they've got to come in and out of the hospital 3 or 4 times and they've not been vaccinated during the workup. And number two is you're going to vaccinate them during a period of immune therapy. So again, it comes back to just do it as soon as you can. And I think that and you might say, well, look, if you've got patients who are on cycle number 5 of 6, and they've got 3 more weeks to go, why not wait till that's finished? And then, but the data, or the T cell data, suggests actually the immunosuppressive effects of chemotherapy don't go away 1 or 2 weeks after they're complete. It takes much longer than that. So I don't see the logic in waiting 3 weeks after chemotherapy to vaccinate. And if anything, you're putting that patient at risk during that period of time. So I would put it to you in a different way. I would say you've got to come up with a strong reason why you wouldn't want to vaccinate the person in front of you right now.
Right. Great. So another big unanswered question, I guess, for the medical community and for society at large, of course, is how long the COVID vaccines will offer protection. So maybe Professor Liebert can comment on this. When do you think experts will be able to provide an answer on duration of response, and is there any evidence that the duration will be shorter for patients with cancer?
So that is a very important question again. And the answer is somewhat controversial around the world. So there are people who say an immune response to a SARS coronavirus will last for many, many months, probably years. And others say it's waning rather rapidly. So from a study that we have done here in Leipzig in pupils, in school children, and in their teachers, we have seen that from May of last year till end of November, there was no drop of the antibody response. So those who had already had the infection, they still preserve the antibodies for at least 6-7 months. Having said that, we of course do not know, really do not know, how long the antibody response will be present, and can be determined probably after 1 year. And that, of course, that means, will we have a new vaccination round after 1 year or after 2 years or whatsoever. That's something that we can decide in the future. For the time being, we really do not know for sure. The other question is, of course, how long does an immune response last in cancer patients? And that obviously depends on the type of treatment. So if you have an immunosuppressive treatment, then which interferes with T or B cells, then you may have interference with the immune response to coronavirus and the immune response after vaccination. So again, this is something that we have to observe, and we have to observe closely and to decide whether really the cancer patients lose their protective immunity more rapidly than the rest of the population.
Great. Thank you. So now a few speakers have mentioned the fact that cancer patients have been excluded from the COVID-19 vaccine clinical trials. So there's obviously a vacuum of knowledge. And I'd like to ask Professor Kanasvaran, what work is being done to learn more about optimal vaccination strategies, for example, through registries, and when will we be able to fill in some of these missing answers, do you think?
Thanks, Ben. That's an excellent question, which again, like many of my colleagues, we still do not have answers to. There are efforts around the world. Some are institutional, some are via societies. ESMO has it as part of its call to action, as I mentioned, which is the component on monitoring, which is diligently collecting data. So that's an essential part in us knowing more about this. Other societies are doing this as well, ASCO. And like I mentioned, individual cancer centers are starting to do this. And this can only be done once the vaccine is available for your patients. So once it's available and you start accruing data about these patients, and if you have the ability to collect blood from these patients and extend it into the realm of doing clinical research, then you can collect more robust data that will be useful for us, in time to come. So that's where we are right now. And I think a lot of this has to be also contextualized to the locality you're at as well. So for example, when organizations have come up with recommendations, and Tom mentioned very rightly, we don't have the luxury of choice now. Whatever you have available, you have to use, even if the data is not there about how long the immunity will last, how well will it last, how much of an immunity you will mount. It's irrelevant because it's essential for you to get it, or otherwise when you get an infection, you're talking about something that's going to cause mortality. But in other places, for example, where I'm at in Singapore, our infection rates are pretty low. So we have the luxury of time to actually think very carefully about the timing of when to give these vaccinations with regards to the type of treatment, whether it's immunosuppressive, when we can actually give it in order to actually get the patient to mount the best response possible that will protect them from the disease. So we have to contextualize some of these advice to localities as well.
Great. So finally, a question for Professors Peters, Powles and Kanasvaran about the challenge of communicating with patients, which we've obviously touched on, but is going to be a big challenge. How are you going to communicate a clear message around vaccination and oncology, and how can you manage the understandable concerns of patients with cancer, both before they get their shots and afterwards, and in order to make sure they get the same benefit from vaccines as other people? So I don't know who wants to start with that one.
I can maybe start in 2 words. I just start, my colleagues will continue. We started here to deliver the vaccine according to 5 categories of priorities, and cancer patients are in the first category, first tier. So we started to massively vaccinate these patients. And the message are maybe of two parts, which are very important. The first one is the one Tom stressed many times, is it is safe to get the vaccine. Despite everything you can read on Twitter, on Facebook, or I don't know where, it is safe for cancer patients as it is safe for the general population. That's the first thing that cancer patients have to understand. The second thing is, whatever the final level in terms of granularity of protection which will be given by the vaccine in each individual and each cancer patient, some protection is better than nothing, whatever happens and whatever the data will tell us in the future. So there's really probably absolutely no arguments now to think that a specific category of cancer patients shouldn't receive it. And unfortunately, the other side of the mirror to try to communicate around this topic is about verbalizing, and I know we don't like to do that, but verbalizing the mortality of COVID infection in cancer patients. We don't like to do that because somehow it's frightening and threatening for our patients. But now that we have vaccine and where you have vaccine, it's maybe the time to make people understand why we stress, we push, we promote vaccine in cancer patients.
So to build on what Solange said, I think that one of we are also vaccinating our cancer patients aggressively. What the patients who come and see me ask me is, they say, number one, is it safe? Because not just because of the vaccine, but because of my cancer treatment or because of my cancer. And that's the signaling around that is very important, because when you go to your GP or your local doctor, they don't necessarily know the answer to that question. And so many of them will come in saying, I'm not sure if it's safe, and I've spoken to my GP. And for that reason, I suspect uptake in cancer patients will be a bit lower than we would like. Because obviously, unless we communicate with the patient that it's safe, they're probably not going to have it, because they're all sensible people and they don't want to do things their doctors haven't recommended. So there is a really important role for the oncologists to broadcast this message to their patients that although the vaccines are safe in the general population, they're also safe and important. In fact, even more important in you. And I have very few patients who don't come and ask me that question. So that's really important. That's number one. I think number two is actually, as a group, because they're on systemic treatment or they're having complicated treatment and they have a general trust in the healthcare system because they're involved in it, there are very few of them who don't want to have the vaccine. So number one, it's an ideal population to communicate to, because they have uncertainty, but deep down they want to go forward and have it. So if we communicate well, we can turn what would be a 20 or 30% uptake into a 90 or 100% uptake. So the messaging in this group is extremely important.
Yeah, just a few more, I mean, nothing really much to add. I think Solange and Tom had very nicely put it. Communication is key, both at the individual level and at the group level. And I think the other thing is also to try to dispel that. You see, now in the age of social media, there's a lot of fake news. So patients are, very influenced by a lot of things that they read. And one of the things that will help in the communication process will be data. And that's why it's important from this point on for every individual center to collect as much data as they can with regards to the efficacy of these vaccines in cancer patients. Definitely the most vulnerable group amongst them will be older adults with cancer as well. So it's important to collect all this data. And as we get the data, to push out this information to bolster support for the use of vaccines in cancer patients. Because otherwise we are competing with unknown factors or unknown information and fake news that obviously is really attractive for many people to read because it's sensationalist stuff, especially highlighting certain toxicities or side effects, which are rare, they happen, but it will influence people's decision-making skills, especially cancer patients who are in a really tough spot during this pandemic.
Great, many thanks for all that. So that concludes the roundtable part of this meeting, and I'm going to now open it up and ask some of your questions, which hopefully have been piling up here somewhere on my computer. Yeah. So a first question for Professor Peters. So with some of the vaccine side effects, such as enlarged lymph nodes and higher temperature, resembling the symptoms that would otherwise be very worrying for people with cancer, should there be a recommendation that patients be counseled and prepared that these symptoms may occur at the time of vaccination, and maybe especially after the second dose, and what kind of plan should be put in place for managing this?
Well, it's all about communication, right? We probably, because of all the digital media kind of polemic arguments we were able to read, we need to communicate a little bit more accurately as compared to the usual influenza flu vaccine, right? But basically what is to be told to the patients is some days after the vaccine, there might be some quite specific side effects that you might observe, which is a short course of fever, some pain, some fatigue. And it's interesting because this enlargement of lymph nodes has been observed. Even on Twitter, you have some impressive picture, but it's just some days and then it goes better. So some kinds of inflammatory symptoms that every one of us has suffered from during any kind of infection, and we know what it can look like. So what I would say here is a word of kind of feeling confident about the short-lasting symptoms which might appear. And maybe the second message is, if it lasts too long, like more than 48 hours, and something looks exceptional or out of the range of what has been described, is to contact the oncologist, right? I think more than ever, we receive a lot of emails, a lot of questions, a lot of phone calls, and we understand why. It's not a problem. We are here also to try to answer infectious disease questions, but we start to learn the answers. So it's absolutely not a problem also to be connected. But I would say we need to describe the side effects, or maybe we have now created here a little cartoon picturing what can happen and for how long and what is usually observed. So it can help cancer patients who already have a lot of things to keep in mind.
Okay, great. So this question is for Professor Kanasvaran. We've had a lot of questions on this topic of vaccine efficacy. So the question is, how do you see the generalizability of the Moderna, Pfizer, and AstraZeneca vaccines to the rest of the population, and also cancer patients, given that 90% of the participants recruited in the trials were white and immune suppressed patients were not included, which is something we talked about a bit, but right. Yeah.
Yeah, so again, going back to what we mentioned earlier, cancer patients were not recruited into these studies. We don't have Asian patients in these studies as well. For example, the Pfizer study was done in 3 countries, the US, Brazil, and Argentina, for example. So I can see where the person asking the question is coming from. So whilst we don't have that, I don't think we also have any data that the vaccine response is going to be different from a genomic standpoint, at least from an ethnogenomic standpoint. So the best way, again, to answer this question would be, a few of the countries in Asia have received the vaccine right now. And of course, some of them have got vaccines that are not approved in Europe and US, for example, Sinovac or Sinopharm. India has their own vaccine as well. So there are different vaccines. They're not mRNA based, but again, we can still collect that data and in a couple of months actually provide an answer to this question. Personally, do I think there's going to be much of a difference? Probably not. I mean, we've seen this with other vaccinations as well, inactivated vaccines like for influenza, pneumococcal vaccine, no real difference between people of different ethnicities. So I don't foresee there to be a difference there. There may be differences, maybe slight differences between the vaccines, and we've seen that in terms of efficacy. Especially now, that some Sinovac data has come out of Brazil, but we won't know until a couple of months down the road whether truly there are going to be differences or not.
Right, thank you for that. So this is a question I think either for Professor Pauwels or Sander. It's about the lipid nanoparticle element of mRNA vaccines, which we know may be taken up preferentially by tumor cells due to leaky vasculature. Could this mean, A, there might be a need for higher vaccine doses, and B, how might that affect, how might the tumor cells acquiring the viral spike protein, might that affect immunotherapy?
Do you want me to dive in with that? So I think it's an interesting question. I think it's an interesting question. And I think one of the other questions which we haven't addressed, which I can come back to this question, but there is an issue around the adenoviral vectors vaccines and whether or not actually we can generate antibodies to those in the future, and therefore it may be that this lipid molecule is the best way of delivering these in the future, and I'd be interested in other people's opinion on that. So the first thing is that this technology, the Pfizer Moderna technology, may actually be the long-term technology that we use. Uptake in cancer cells, well, we've been using this type of vaccination in our cancer trials. We actually got trials open right now using exactly this technology with personalized cancer vaccines, where we send the tumor off, we make RNA, and we re-inject this way. Now, and that doesn't seem to, I mean, whether or not the trials are going to be successful, we don't know the answer. There's some randomized trials. We took part in the phase 1, phase 2s, but they don't seem to be harmful to cancer patients, firstly. And secondly, yes, we've seen some responses, but we don't know whether or not that's related to it. But really importantly, this technology is totally unrelated to that. That the technology that we're using on the cancer patients is a personalized approach where we're getting the tumor, munching it up, generating RNA to that, re-injecting that way, and maybe seeing responses, maybe not. This is completely different, where obviously we're getting the viral RNA for the spike protein. And if it's going into cancer cells, that's okay. The key is it goes into antigen-presenting cells, and we activate MHC class 2 and go down and get antibody responses.
Great. So quite a lot of questions about the timing of administering the vaccines, which is something we've covered a bit, but so here's a particular question. If a patient is receiving chemotherapy and was vaccinated just before a round of treatment and developed a fever or other mild adverse events, would the subsequent round of therapy be postponed? And sort of another question, any insights as to whether it could theoretically be beneficial to withhold GCSF administration if a COVID vaccine is administered shortly before the chemotherapy?
I can try to start, but I would be very happy to have the answer of Dr. Sander about the GCSF. But basically, usually when you have a patient with fever, as a general rule, you don't like to start chemo. So I would say if by the intersection of bad agenda, you have a patient receive the vaccine, tomorrow the chemo and fever, postpone your chemo for 2 days and give your chemo afterwards, so you're safe in what you're doing. It's a bit about following the standard guidelines. But there's no biological intersection that I would fear there particularly, apart from the fact that you give steroids with chemo usually. If you can avoid to give steroids the same day or right the day after you have injected the vaccine, theoretically might be better. And like Ravi was telling, if you have the luxury to choose, try to stay a little away from these pulsed steroids. But again, pulse steroids are not strongly immunosuppressive, right? But if you can avoid to simultaneously do two things which are supposed to be contradictory, it's probably better. About the GCSF, I don't really see why there would be a risk or a contraindication of stimulating the granulocytes and the stem cells for these ones by giving a vaccine. So I wouldn't change anything into the cancer best practices according to the usual standards of care and guidelines. So I don't see any limitation there. Dr. Sander, would you say anything about vaccine and stimulating the granulocytes, the GCSF components?
No, I don't see any issue there. I would agree with the previous speakers that if you can extend the interval between the vaccine and any subsequent chemotherapy or immunosuppressive treatment, that's obviously, if you have that luxury, that's obviously preferable. I don't actually see any counter indication to giving GCSF together with the vaccine. I mean, again, any cancer treatment should probably, you would, if you can, you should probably have an interval between the two, just as you would with any other treatment, if that's possible.
Great. So another question on timing. So when is it better for a patient under TK inhibitor treatment to receive vaccination? So should it be during the weeks before when they take the treatment, or the weeks when they're not taking treatment?
For the tyrosine kinase inhibitors or TKIs, you said?
Yes, I think yes. think that's what they mean.
Educated guess, right? Some of these TKIs might play a role in stimulating the immune systems. That's all I know about immune system and TKIs. We know the MAP kinase pathway can play a role there. But in any case, what I mean is, if anything has not been shown to impact the severity of COVID infection, probably not at all is TKIs. So I would have the same thought about, by paralleling the thoughts, right, about vaccines in TKIs treated patients. I would say probably that the kind of treatment with hormonal treatments where I would give the vaccine somehow a little bit regardless of what is ongoing with the treatment. But I don't know what, Tom is giving a lot of TKIs. So what do you think, Tom? Ravi too, right? Both of you.
I do give a few TKIs. And I did a clinic yesterday and we vaccinated all our patients irrespective of the timing of their schedule. There isn't any evidence that the way we get out of it is we vaccinate as many people as quickly as we can. And that's the bottom line with this. So there are theoretical reasons that we can debate over a period of time, but sending someone away to go home, particularly in London right now with the height of the pandemic, to come back in a couple of weeks for the theoretical risk that the T cells might be working slightly better because of sunitinib, that's a discussion for the future. Right now, let's vaccinate the people in front of us. That is the way out of this. This is how we will protect our patients.
No, I fully agree with Tom. With the TKIs, there shouldn't be any issue, and you should go ahead and just get vaccinated, regardless of, like you said, even if the regimen has periods where you're off the TKI, the sooner you get the vaccine, the better.
So this is another question for Ravi. Given your expertise in geriatric oncology, should vaccination be, not be withheld in patients who are simply too frail due to cancer? Do you see a cutoff there? No,
there shouldn't be a cutoff. And even if the patient is frail, the last thing you want is for the patient to contract COVID and die from that. So these patients, in fact, should be prioritized. They should be highest on the list to be protected. And that's where I think COVID, unfortunately, played a role in marginalizing older adults or elderly folks with cancer, because when they did get COVID, they're the ones who, we rationed, who lost out when there was rationing of beds, when there was limited resources. The folks that didn't get treatment were the older adults, because when they triage, these were the ones that, institutions, they had to choose, and when they were not prioritized. So if anything, older adults with cancers should be prioritized when it comes to vaccination. They should be the first that we should try to protect our elderly folks. So yeah, that's the answer. So even if you're frail from your cancer, but you still have relatively good prognosis, you should get the vaccination so you do not contract severe infection from COVID-19.
Great. So the question for Professor Liebert, we've already mentioned this. We're getting lots of questions about the possible effects on delaying the second dose, as some countries are planning to do and are doing. So any thoughts on the impact of delaying the second dose on the vaccine in terms of vaccine efficacy and protection generally, and particularly in cancer patients?
Well, do you hear me? Yeah.
Yeah.
That's probably not the case to differentiate between cancer patients and the rest of the population. But delaying the second dose of the vaccine will leave a certain percentage of the population not fully protected. So you have some percentage of population that have a partial protection. They could be infected. They could then have the virus under some immune pressure and are probably forced to mutate to circumvent this partial immunization. So delaying a second dose would be, at least on theoretical grounds, would be quite risky, because the amount of mutations that arise could be higher. That is not proven yet, but it's very likely from what we know from the other infections, what we immunized before. So the likelihood of new mutations arising would be higher. That's my guess.
Okay, thank you.
Mm-hmm.
Yes, sorry. What?
I would just like to comment on that. It's an issue I've actually been thinking about a lot. I know also we have panelists from the UK, and it's an issue that's being debated in Germany. I think at the moment we have too few vaccines for the number of people at high risk for severe COVID. We have still very high numbers, and we are in risk of those numbers going even further up if some of those variants spread even further. I'm not sure whether delaying the second dose would actually create that type of immune pressure for SARS-CoV-2 to mutate. I think those early escape mutations that we've seen came out of areas in which there was very high natural immunity, such as Manaus and townships in South Africa, where probably vast parts of the population had already contracted COVID, and that's where we see those 484 mutations and so on, which have been shown to slightly alter binding of neutralizing antibodies. While the other mutant from Britain, or first described in Britain, does not seem to impact the immune response or neutralizing antibodies. So we're really from an immunological standpoint, stretching the interval between boost and prime and boost in the end normally leads to a stronger boost response. So 21 days, as it was done in the BioNTech trial, is to me the absolute minimum time you should wait between 2 doses of a vaccine, because you're vaccinating into an actively ongoing germinal center response. And I think there's data from the AstraZeneca trial that shows that those vaccinated with a 12-week interval had considerably higher antibody levels in the end. So yes, you are opening up a little window with a few people that have just received one dose. I think the protection data from the phase 3 trials argue that the protection is fairly decent even after 1 dose. And I agree that in vitro systems that titrating in antibodies can create the type of immunological pressure that would drive mutations. But I don't know if, because we're so far away from herd immunity here in Europe, that just stretching that interval in that time frame where we have too few vaccines available, which is the case and it's going to be the case for a few more months, whether that would actually be in danger. I agree it's a theoretical danger, but I think that the positive effects probably outweigh this. So I think it's a strategy, especially if we're talking about getting the vaccine to groups that have not been prioritized so far, such as people on immunosuppressive therapies and cancer patients and so on and so forth, that we should debate whether we can somehow keep this interval flexible and get more vaccine out to people that are in urgent need. And so I agree with all the arguments, but I think we need to calculate the risk. And I've seen some modeling recently that was done, and I think in bottom line is you can save more lives if you go out and stretch that interval a little bit, whether that is 12 weeks or maybe just the 6 weeks, and the 6 weeks are fully covered by the data from the trial, right? The Pfizer trial, patients were vaccinated between day 19 and 42, and that's also what the German guidelines say. That's the interval that you should use, but already that could help, and not basically keeping half of the vaccines in a freezer, just waiting for the same people to come back, but get what you have, you should bring it out to the people that need it. That was just something I wanted to comment on.
Great.
I think that's a really complicated issue, and my feeling on it, I think we need to see the modelling on this. Clearly, the UK has taken what I think is a slightly eccentric position of not offering the second dose, and I think that there is a real obligation there. Clearly, that is not a decision that you can take lightly in such significant circumstances. There is limitation of the amount of vaccine we have available to us, and that's reality. A decision about vaccinating 10 million people with 2 or 20 million with 1 is a discussion that's clearly taken place, and I suspect at a very high level, and there must be very accurate modelling which they made a decision to pursue based on that. And what my feeling is, as healthcare workers who are putting ourselves at risk during this process, I think it's important to see that data, because if indeed the number of deaths for the population is reduced by that, with all the theoretical risks of having 1 versus 2. I think it's important to see that data, and I haven't seen that.
If I might just answer to that, there is the one extreme of just saying, I'm just going to give 1 dose and see what happens. And the other extreme, as we have in Germany, we will stick to these 21 days as it is a law, and we'll always keep 50% stockpiled. And I think there is a gray zone between those two strategies. You can say, we'll give it between those 21 days and maybe 6 weeks, debate about if it's 6 weeks or 8 weeks or whatever, and not stockpile everything. But, you know, we have vaccines sitting in the freezer right now, not giving it to people just because, but that's what we do. And I think there's a gray zone between those two extremes, and we need very accurate modeling, I agree, so that we can find the sweet spot in between those two. The vaccine was licensed for 2 doses, so I think it's wrong to give it just as 1 dose. That's not how it was tested, and we don't have data for that. But we do have data to give it after 6 weeks. So why should we, you know, stockpile half of the doses just to be able to give it exactly at 21 days, such as is done here? I think that is also not the right strategy.
Okay.
Yes,
So
I totally agree with you, Professor Sander. What we should avoid is to forget the 2nd dose and probably prolong the interval for 1, 2, 3 weeks or 4 weeks. That would be okay.
Okay. I'm afraid we're already past the hour, so we're going to have to wrap up soon. But I wanted to ask just one last question to Professor Peters. So ESMO clearly is, you know, advocating priority for cancer patients. But what about pediatric groups and caregivers? What are your feeling on where they should rank?
Yeah. Well, basically, you think about pediatric cancer patients, right?
Yeah.
The question would go back to the colleagues from infectology. We have very low level of data in children in general, right? So what would be the case about 2 things? First of all, the general mortality and risk in children suffering from cancer. I know that St. Jude, some hospitals have tried to deliver this data showing some level of risk in these cancer patients, but lower than adults. But still significantly lower than adults. And the other thing is how the vaccine will work in these patients. So I will let that to my colleague from infectiology, because basically I must say ESMO would not position itself as being meeting this gray zone arguments, because we don't have any data about it, and it's usually out of the range of our activity, which is mainly about adult oncology. The second question was about
caregivers.
Okay, of course. So that's very important, because ESMO is, first of all, also the organization of the many caregivers and members, everyone who treats and takes care of cancer patients. So I fully agree with Tom. He told it several times. I think you cannot build a system where the people who deliver the vaccine are not vaccinated. You cannot build a system where the pressure is put on the shoulder of people who put themselves at risk without prioritizing them. I was telling in the first year, we have cancer patients here. The second cohort of people is the caregivers in Switzerland. So cancer patients, very fragile patients, and caregivers. In the US, many big centers have started to only vaccine caregivers and physicians, and to go to patients as a second, very close, of course, but a second round. And I find it justified, because the whole skeleton of everything we do, including delivering vaccine, is on the shoulder of the caregivers. So that's absolutely obvious to me. For the children, I will let my colleagues answer, because there's nothing more in medicine than telling stupid things. Dr. Sander, children?
You want to quickly answer that?
The whole question around vaccinating children or not, I think hinges on whether those vaccines can induce sterilizing immunity. The individual protection for kids is probably, or the effect is low, because, as you know, there are hardly any kids that we see that are severely ill if they don't have a very severe underlying condition. And so the individual benefit of getting vaccinated is very, very low. So I think if we can see that this significantly reduces transmission, we have to discuss that, and then we have to see the data from the trials. And if that's not the case, I think we need to have a very serious discussion around vaccinating kids. This virus is going to become endemic in any case. So we're not talking about eradication. So in that case, I think and kids are probably going to acquire natural immunity.
Great. Okay, well, I'm afraid we're out of time, slightly over time, in fact. We got more than 100 questions, I've just been told, during the roundtable. So thank you all for asking all those questions. And obviously we didn't answer them all. The ESMO team will take away the questions, and they plan to provide answers in the next few days. They'll be on the website, esmo.org. And also, if you look at the cancer portal, the COVID-19 and cancer portal for this event and others, there'll also be other materials there. And I think there's some more webinars on this subject coming up next month, so watch out for that. And just to say thank you very much for all the panelists for taking part in this very fascinating and important discussion. And good afternoon. Thank you.
Thanks a lot. Bye-bye.
Thank you. Bye.
Bye.
Thank you very much. Bye-bye.